Okay, first I want to thank you for the invitation to here speak about aspects that are related to therapies in children with cerebral palsy. So today the ICF framework, which is basically intended for classification, it can also be used as a framework for therapeutic thinking. In this lecture I will talk about, first I will introduce the ICF, the children and youth version. I will give you a case scenario to understand a little how we look upon this classification. I will make a short overview of cerebral palsy just to show the heterogeneity of the group and why we need classifications. I will also, as Professor Forsberg showed, take some instruments and put them into the ICF. And then I will look at some therapies and how the relations between what you do and the effect in the ICF. So the ICF stands for International Classification of Functioning, Disability and Health. And here you see the Swedish version. And as I said, it also exists a version for children and youth, which takes into account aspects of development. But what does it mean that it is a classification? So to classify is the act of distributing things into classes or categories of the same type. So here I have another classification that you might be familiar with, the famous Swede Carl von Linné, who did this classification where he grouped species according to shared physical characteristics, the biological classification. And I guess now most of you are familiar with this picture showing the domains of the classification. So you can use to identify and sort the various motor disorders and also accompanying disturbances that can be observed in children with cerebral palsy. So the ICF shifts the focus from cause more to impact by describing functioning and health conditions from various perspectives. And functioning is the overall term that covers all body functions, activities and participation. And the contextual factors form the background of the individual's life and also include environmental factors and personal factors. And this classification exists in multiple languages, and that is because it is used all over the world. So the ICF provides a framework for guiding clinical thinking, for assessment, for example, and also to think about the impact of different interventions, and also for measuring health and disability, both at an individual level but also at a population level. It can be used to explore research questions. It can be used to make comparisons between cultures, countries, gender. It can be used as communication between researchers and clinicians, and also to confirm, to generate, and to apply theory. And also, I think you could think of other purposes. So opposed to health in this WHO model is disability, which serves as an umbrella term for impairments and activity limitations and participation restrictions. So a simple relationship within this framework would look like this. You would see that improved body function, here improved strength, could change the possibilities of participation in a life situation or fulfilling a life role. So this is how we sort of view interactions within the ICF. Now I would like to give you a case description. And the age of this patient is unknown. I think probably between 7 or 9 years of age. And the diagnosis, with some difficulty, it was classified according to the ICD-10 that most of you are very familiar with, which is a classification for diagnosis. But it might be classified as Q75.9, which would be congenital malformation of skull and face bones, unspecified. And this patient lives with his family and relatives in the Rocky Mountains in Canada. And he likes physical activities, but also philosophy. And here he is. His name is Hubert. And he has this change in body structure. You see, he has these really big horns. And if we could go into the ICF and classify them, they would have the code S710, which would be structure of head and neck region. You know, this is going to be a fairy tale. And as I'm a physical therapist in pediatrics, I sort of like fairy tales, and I'm also a bit childish, so I hope you will enjoy meeting Hubert. And as you can also see on the next slide, he has some activity limitations in this environment where he lives. They could also be classified as D429, I think, D420. And so this is really a problem for him living in the Rocky Mountains, where the environments put restrictions to this impairment or change in body structure that he has. And also this has an impact on his participation, which also could be classified in the D domain. And it says here that the family, they were really upset about what had happened to Hubert. And so they really tried to help him all the time. But he felt that he didn't like to be helpless like that. So he said, maybe I could solve this problem in another way. So here we can stop thinking, if Hubert had had a habilitation team around him, what could the different professions have done? And I guess if there's any orthopedic surgeon out here, they would immediately think of cutting the horns. Wouldn't you think that that would be a good solution? But we know very little. There's very little evidence for such a thing to be done, or such an operation, because we don't know. The horns might grow twice as fast and in different directions, might be even more impairing. But if he had a physical therapist there, maybe she could teach him to jump, or an occupational therapist would look that there would be some things that they could lay out so that they could walk with not having to jump all the time. And maybe a social worker could speak to the family and say that they shouldn't help him so much. Or a psychologist could talk to Hubert, and he could talk about how he experiences having this impairment. Now the thing is that there was no habilitation team here in the mountains. So Hubert, he stood up there and he looked down in the valley, and he could see that if I was down there, maybe my life would be completely different. So he actually decided to leave his family and go out all alone in the world. And as you can see, it was very much easier for him to function here. The environment is much more adapted to this impairment or change in body structure. But then after a while he felt very lonely. So he found this herd of cows, and they said, okay, you can come and stay with us. But they didn't care very much about him. He was not really included. But one day when he was there came this helicopter, and they saw Hubert with his big horns, and in the helicopter were hunters, and they wanted his horns. So he ran out into the woods, and then this happened. He fell over this thing, and he thought, well, now my last moment has come. I will not survive this. But then he comes into to this skiing slope. So you can see that all of a sudden he's part here of a group, and he can ski on his horns. And they come to get him, and he's one of all the people who are there. He's really participating in this group of skiers. And the environment is also really adapted. It doesn't need any changes. So you see, you have the whole ICF in this. And finally, they also was like people came from all over the world to look at Hubert, who could ski on his own horns. He was the only goat in the whole world that could do this. So this is a way to view full participation. So okay, you feel you have an idea now on how we look at the ICF and how things relate to each other within this framework. So with this picture, I just want to see where I am. So how you view a problem determines very much how you will try to see it. So the ICF can provide this framework. And I think you're all familiar with this picture, where everybody is blindfolded, and nobody sort of can determine that this is an elephant. Somebody here in the front will say this is a spear. Another one feeling the trunk will say that this is a snake, this is a tree. So we really need a unifying framework to be able to view health and disability. So now I will move to the to children with cerebral palsy, and here with the aim to show how important it is to classify various aspects of functioning, since the disorder is very heterogeneous. So this new definition, which you see here, points out that the disorder is permanent, that it has to do with development of movement and posture, and that the disturbance occurred in the fetal or infant brain and is non-progressive, but the symptoms are, however, progressive. Some of them. So the accompanying disturbances could be many, such as disturbances of sensation and so on. And these disturbances can sometimes be judged to be more disabling than the motor system. I met one of my old patients the other day, and she judged her central visual impairment to cause her more difficulties than her motor functions. And the heterogeneity of symptoms has its root in the diverse etiology. So where the timing of the lesion, the site of the lesion, and the size of the impaired area are of importance. And this is from a publication by Ingeborg Kregelå Mann, where you can see that early during pregnancy you have more of malformations, and then between week 24 to 34 you have more white matter lesions, and later during pregnancy gray matter lesions. Doesn't work? Okay. To bring some order, can you hear? Yes? To bring some order into this heterogeneity, I will go on. I can go on? To bring some order into this heterogeneity, the children are first classified according to diagnosis, which is related to the predominant symptoms and according to distribution. So you have bilateral or unilateral cerebral palsy, and then spastic, dyskinetic, or ataxic. And then also the children are classified according to the gross motor performance in GMFCS, in the gross motor function classification system. And you know that they are divided into 5 levels that span from level 1, which are children that walk independently, and to children level 5 who have severely limited self-mobility. So, and also to accommodate the changing abilities with increasing age, you have 5 age intervals. And I think this is important because this classification is of prognostic value, which is a very important aspect of this classification for therapists and parents, and also the child. So you can early on in life have some idea about the prognosis of the child. And then also hand function can be classified, and that Professor Eliasson will present. And presently also a classification for speech and language is under construction and will soon be published. So then these various classifications, which are very easy to do, and possibly can also be reliably performed by the child's parents, they will give a clear picture of the child's functioning with very few words. So now back to the ICF classification, and I will present relations in children with CP within the domain of body function and body structure, and also between this domain as a body function and activity. These type of relations that I talked about earlier. Somebody has changed this picture. So this picture, you've already seen part of it. So these are various aspects of human functioning that can be measured, and you see the abundance of instruments to measure body functions in relation to gross motor capacity and gross motor performance. So gross motor capacity represents the child's best ability, and performance represents what the child normally does do in daily life. So here, body functions of interest are muscle tone or spasticity, range of motion, selective muscle control, strength, muscle fatigue, sensibility, and SAROM is spinal alignment. And other aspects of importance in children with CP could be, for example, cardiovascular fitness and so on. But here an important question can also be asked, which was already raised by Professor Forsberg. Is the chosen measure valid and reliable? And I will not go through all the instruments for measuring that I mentioned, but I will linger a little on measuring muscle tone or spasticity. So you might remember that I had showed 3 measures: the Ashworth scale, the Tardieu scale, and the hypertonia assessment tool. So there are 2 definitions of spasticity, which has to do then with validity. How do you define a certain concept and how do you measure it? So the first is a well-known definition by Lance from 1980, where the velocity-dependent hyperexcitability of the stretch reflex is emphasized. But with the second, by Sanger and collaborators, the importance of the movement direction is also emphasized. So the hyperexcitability of the stretch reflex is related to the spinal circuitry and all the mechanisms in the at the spinal level that could affect this hyperexcitability. For example, decreased presynaptic inhibition, a lack of recurrent Renshaw inhibition, also the influence on the alpha motor neuron from the 1B afferents from the tendons. And the hypothesis here is that the hyperexcitability can be graded by the Ashworth scale that you see on the other side, where the muscle is stretched at a specific speed, which is normally about 180 degrees per second, and that you feel it as a catch at different places in the available of motion. When using the Tardieu scale, you also get the more passive component of the muscle in relation to this fast stretch. And with the hypertonia assessment tool, you have a distinction between spasticity, dystonia, and rigidity. And that is more related to the definition by Sanger. So you understand that what you measure has to be defined, so the validity of the measure is very interesting. So this picture is just to illustrate that an increased resistance to stretch in a spastic muscle can be task specific. So this is during different phases of gait, early stance, and in the mid-swing. And here are typically developing children and children with cerebral palsy. And this is the increased speed. And you see when the child with CP is standing on the foot, you get this increase in activity in the muscle, but not during the swing phase. So during active conditions, this is very task-specific how the spasticity is expressed. So I would like just to give a few examples of the relation between spasticity and range of motion that also Professor Forsberg mentioned. So this is from a study of 2004. But I will just bring out the relation between a modified Ashworth scale and passive range of motion. And you can see that there is a relation between, in these 95 preschool children, between spasticity and the number of and the decreased range of motion. But it's not a very clear relationship. You can see that there are children with very high spasticity who doesn't have so much decreased range of motion. So there is not a cause-effect relation. And this is just to show how the big variation within the group of children with CP. You have children about the same age, but different GMFCS levels. They all have quite high spasticity in the dorsal extensors, but the range of motion differs very much between the children. So in the clinical practice, there's a lot of variation, as most of you know. And this is the study that Professor Forsberg talked about from Tedroff and co-workers. So I will not go through that, because the message was that reducing spasticity there's not a clear relationship between increasing range of motion. The range of motion also decreased over time. But what is then the relation between spasticity and activity? So this is a study by Jan Wilhelm Rother and co-workers. They measured spasticity with the Tardieu scale in 3 muscle groups and related that to the development of gross motor capacity, which was measured by this gross motor function measure over 1 year. And they found that the degree of spasticity was only marginally related to the development of gross motor function. And I think this is a very important study that needs to be replicated, because it seems like we cannot predict gross motor function from the degree of spasticity. And another study, which also looked at Virginia Wright and co-workers, they were interested in how changes in spasticity related to changes in activity. And they did this intervention and measured activity by the GMFM. They also had other instruments. And they saw that the children, they changed in all the measured parameters, but there was no correlation or very low correlation between the change in spasticity and the other changes, which I think is a very intriguing finding. So what we can say that we cannot at all be sure that relations or interventions that go to body functions really make a change in the child's activity dimension, in gross motor capacity or in gross motor performance or in everyday life performance. And this really needs to be investigated. And here the ICF can help us a lot to form theories around this. So now I would just like to finish by shortly coming from the other end of the ICF, by moving in from activity and participation and see how can an intervention at this level affect body functions. And here we have quite a lot of studies already, and some of them are rather well known. For example, the study by Marjolijn Ketelaar from 2001, which is a very good study. And then I've two of them that look red there are the studies that we recently performed in Stockholm, and that I will present the results very shortly to you. So what measures did we use here? We used the GMFM, gross motor function measure, and we also in activity the PD, which is the Pediatric Evaluation of Disability Inventory, which has 2 different scales, and when the activity domain is the functional skill scales. And here is the GMFM. I think you might be familiar with this. It has gross motor items in lying and rolling, sitting, crawling and kneeling, standing and walking, running and jumping. It's much like things that are done here at this clinic, but this is really structured, and it's been tested for validity and reliability, and the measure has improved over the years. And PEDI, that is an interview with the parents on 197 items within self-care, mobility and social function. And the parents are also asked questions about how much help they give their infants. And this is also a widely used, worldwide used instrument, which is found to be very reliable and valid. So, and besides these instruments, when you use goal-directed therapy, you also set goals for the child, and these goals are set in very close collaboration between parents and professionals. And the different measurement instruments, the PEDI, the GMFM, are used as a basis for discussing which goals that could be set. And Ann-Kristin will also talk about how children themselves can set goals. And so you see, you make a scale, which is a very individualized measure. The -2 is you decide the baseline. What can the child do now? How can the child dress? And then you set the goal, which is a 0 level. And then you make a +2, which is a little more than expected, but still a realistic goal. And these goals, they should be specific, measurable, attainable, realistic, and time-limited. So you have an acronym which is SMART. It is SMART. To set this goal, a very thorough analysis of the child's daily performance, the child's optimal capacity, the environment, and the caregiver's behavior is needed. So, like I said before, the GMFM and the PEDI creates these possibilities. And the process of goal setting requires a really close collaboration with the family. And we call this family-centered service, like Professor Forsberg talked about. We've been moving in this direction. And the family and the child are really actively involved in this goal-setting procedure. And they are being responsible for selecting the goals. And the family is involved in decision-making, and the family is active in the therapy by offering practice to the child in the everyday environment. And I've listed some articles there which I think are really good on the subjects. So we did a study where we compared what we call an activity-focused therapy approach and goal-directed therapy approach, and they are rather much alike. So you can see that for the activity-focused approach, you have about the same theoretical framework, and both therapy approaches are integrated in the everyday environment. It's a multi-professional team. But in the activity focus, you have more of individual therapy sessions, and then in the goal-directed, you also have group therapy sessions. And in the goal-directed therapy, you have an initial education of the parents, and goals are set. In this study, 5 goals were set for each child in collaboration between the multi-professional team and the parents. So the children in this study were 44 children. There were 22 in each group. And you can see the diagnosis that they are preschool children. And almost all the GMFCS levels are represented, not GMFCS level 5, and not max level 5 either. And 25 boys and 19 girls. And this is one of the first results after therapy. Can you see this? Oh, you have to believe me and look at it later. So these are all the measurement instruments, the PD and the caregiver assistance and the functional skill scales and the GMFM. And in the goal-directed group, there was a significant improvement in all these measured aspects, while in the activity-focused group, there was not a significant improvement over these 12 weeks that the training was. So the training was for 12 weeks. And if we look at only the group of who had goal-directed therapy, you see here in between, this is baseline. This is a therapy for 12 weeks, so there's 6 weeks between each measuring interval. And this is after therapy. And these are the GMFCS level 1, 2, 3, and 4. So you can see that during therapy, all the children improved significantly. It's what we call a 3-star significance. And then they kept the gross motor function after the intervention. But what about the relation to body functions? Because we measured range of motion, we measured selective muscle control and spasticity. And these children had improved or significantly improved range of motion. But as you can see on the figures, it is within the measurement error, which is about 10 degrees. And all the others, there were no changes. But with older therapies, they said that the children should not be so active. That could increase spasticity, which is absolutely was not the case. And the goals, there were 22 children and 5 goals each, which makes 110 goals. And you can see that most of the goals that the parent choose, the blue is mobility domain of the ICF, and the red is the self-care domain of the ICF. So the goals were linked to the ICF and coded to the ICF. So you can see that this is what one would expect for a group of preschool children. And when we looked at goal attainment, how did the children reach these goals exactly after the intervention, here after, and also at a follow-up period after 12 weeks? You can see that the goals were reached to a very high extent. This is after 12 weeks, exactly after the end of the therapy. So what is really striking, the children should have reached this 0 level, and you can see that they improved much more than the parents and the therapists thought. So maybe the children are a little underestimated. They can do better than we think. So in conclusion, I'd like to say that this group of children who received goal-directed therapy, they demonstrated beneficial effects in everyday performance, gross motor function, and goal attainment, irrespective of GMFCS level. So it was not related how severe their, so to say, disability was. So this active therapy approach did not induce any deterioration in body functions. So these are the publications that I have talked about. So I just then want to thank you for your attention. Any questions?